So the first question was, do you have any recommendations regarding the coding of wounds identified as mixed etiology, for example, moisture-associated dermatitis or pressure? And to code the section M, the primary cause of the wound should be related to pressure. So again, this is that whole thing where you're going to have to use some clinical judgment. You could have moisture-associated dermatitis, but you also have to say, is there, an area, let's say it's near a hip or something, where there could be pressure over a bony prominence near the coccyx. So you'll have to make a determination. So don't call everything just because it's got open that it's automatically a pressure ulcer. The second question is, if the staging is only found in a nursing note, not a physician note, from the previous stay, is that sufficient? And the short answer is yes. The facility should review the medical records, including skin care flow sheets and other skin monitoring forms, to check for any documentation that indicating that a known pressure ulcer exists and what stage it was at. So it doesn't have to be specifically a physician note. Let's see. How would you code a patient admitted to an LTAC, or in this situation it could be IRF or whatever, with fragilely healed pressure wound that opens back up during the admission period of time? Is that considered a progression or worsening of a present on admission pressure or injury, or a new, they had LTAC or IRF associated pressure injury? So basically what we're saying here is that if you have a wound and it's over a bony prominence and your documentation that it was whatever stage and it has just newly healed or epithelialized, and in that first couple days of admission and that exact spot opens up again, that can be considered present upon admission at the stage it was at the previous setting. So if it was a stage 3, but you need to make sure that it's in the exact anatomical position of where it was from the previous setting. And as we know, when that just heals, that tissue is so fragile, that can open up. Let's see. If a patient develops a pressure injury, stage 2, during the stay, but heals prior to the discharge, how is that coded? Well, the pressure ulcer would not be coded on the IRF-PAI or the LTAC care setting admission or discharge assessment, since it was not assessed upon admission and healed before discharge. So that's that wound that happens in between. You got through admission, they didn't have it, they got a stage 2, you healed it, and then they got discharged. So it didn't show up on either one of the assessments. That doesn't mean we clinically ignore it. Certainly we treat it and do whatever we need to do. It just wouldn't be captured in between those assessments. If a patient is admitted with a healing stage 4 pressure ulcer that presents as a stage 2, we still stage this as a stage 4 on the admission. Is that correct? However, if it goes back to a stage 3, the wound worsened on our watch, but this does not count as a worsening injury for us since it started out as a 4. So basically what the patient's saying is, it came to you with what the questioner's saying is, you came with a stage 4. It's presenting as a stage 2, so it's actively healing. And now what I hear them saying is, throughout the stay, it gets a little worse. So now that maybe we're starting to see a full thickness. Maybe they even had some slough in there, and then it cleared away. How would you code that? Well, it's a stage 4 until it's healed or closed, correct? So it's not like you would say, well, it went from a 4 to a 2 to a 3. We don't reverse stage. It is a stage 4 until it completely heals or closes. Question we have here, our wound nurse does not stage, but primarily uses descriptors, which seems to be a trend in wound care. Please provide suggestions on how to reconcile coding requirements with how pressure wounds are documented. And our advice is to use, please review the manual guidance for section M, which gives descriptions of each stage, and then use your facility policy or practices to who can do that. My understanding is in some states, they're considering it outside the purview of the nurse to actually stage a wound. So they actively really describe the wound beautifully, and then you'll need a practitioner like an MD to actually stage it. So then I would say refer to your policies and procedures. But the guidance is in section M. How would you code one unstageable wound that opens to two separate stageable wounds? So this is an interesting question. So you have a wound that is covered with slough or eschar. I'm assuming that's how this question is written. And when it gets debrided and the slough and eschar are gone, what they're describing now is two wounds. Highly unlikely, because you'd have to have epithelialization going on, and usually you won't have that with the slough and eschar over it. But at that point, if for some reason that happened and you had these two wounds, you would count them as two separate wounds on the discharge assessment. And the second of the two wounds, or the new wound created by the epithelialization, would be counted as a new wound because it would not be counted as a new wound as it would be present upon admission. It's kind of the same story that we used when we used to code these. We said, you had a stage 3 pressure ulcer, and or you had two pressure ulcers then that opened up into one where the epithelialization went away. It's the same type of question. Another question, clarify stage 4 wound present on admission that was not stageable at discharge due to slough or eschar. Will it be counted as a new or worsened wound in the now pressure ulcer, the new pressure ulcer calculation? Well, yes, it's counted differently in the new. So if you had a stage 4 pressure ulcer present upon admission, and we went through this in one of the case studies, and that wound then becomes covered with slough or eschar, you have to answer the questions in the section on discharge saying, do you have any stage 4 on admission? Yes. Any on discharge? No. And then as we go further down and ask the questions, any pressure ulcers unstageable due to slough or eschar in this situation? No, on admission, but yes, we have it on discharge. Let's see, let me go down here. Would a wound vac be an example of a non-removable dressing if it is an order to only be changed every 3 days and it is changed prior to admission? Yes, it could be that if that was there and you had an order that you couldn't remove it, yes. Another question, if previous stays documentation does not indicate a pressure ulcer, but an admission head-to-toe skin assessment identifies a pressure ulcer within 24 hours of admission, does that count as present upon admission? And the answer is yes. If the patient is assessed upon admission and is found to have a pressure ulcer, that pressure ulcer should be noted on the admission assessment and would be coded as present upon the admission at whatever stage that pressure ulcer was. And there are some that are going to take a little bit more, it's just too much to go through and read the answers. We're going to provide answers to all the other questions. And some of them we have, we'll refer back to some of the training materials within them. So that's it for pressure ulcers for me. And I know we have a lot of Section M.
Yes, we do. A lot of questions, which is great. We like to answer those questions to clarify your understanding of Section N, especially since it's a new section. So continue, please, to ask us those questions, and you can submit those into the help desk for your specific setting. So the first three have some related elements, but they are distinct, so I will go through each one of those. The process of, first one is the process of communication you're describing is often an ongoing and fluid process of everyday patient care. Not every clarification or MD medicine communication is noted in the medical record. Is CMS considering a significant issue to be those that are reportable for patient safety level? So our answer is that potential and clinically significant medication issues have to reach that level of clinical significance that really warrants the notification of a physician or physician designee for orders or recommendations by midnight of the next calendar day at the latest. So any circumstance that does not require this immediate attention is not considered a potential clinically significant medication issue for the purposes of the DRR items. The next question is, does the communication need to be documented into the EMR, or is a policy stating the process sufficient enough? We said that the data in the LTAC care data set and the IRF-PAI should be consistent with information in the patient's record, the necessary information needed and used to code the items. So all those things that needed to be reflected on to give you the information needed to code those items is the information that should be in the patient records. The next question was, medication issues questions are routinely communicated and taken care of in real time without documentation of each interaction in the medical record unless the error reaches patient. Is CMS suggesting that the patient care documentation practices be changed in order to meet the DRR measure requirements? So again, we say that the data in the LTAC care data set and the IRF-PAI should be consistent with the information reported on the patient's medical record. And again, it's that necessary information that you use to code it, and each facility delivers patient care according to their unique characteristics and standards, such as their patient population. Thus, each facility self-determines their policies and their procedures for completing the assessments in compliance with their state and federal requirements. Next question was, does CMS expect the pharmacist to document the medication review in the patient's medical record? The answer to that is that the data in the LTAC care set and the IRF-PAI should be consistent, again, as we said, with information reported in the patient record, the necessary information needed and used to code them. Each facility, again, this is a policy-driven issue in terms of looking at your policies and procedures for completing the assessment. CMS does not provide guidance, furthermore. Does not provide guidance on who can or who cannot code the DRR items. So please refer to your facility, federal, state policies and procedures to determine which LTAC and IRF staff members may complete a DRR, and each facility, again, will be different in terms of the type of care they provide. It depends on your state, et cetera. The next question was, DRR includes all medications. When you state nutritional supplements, are you referring to nutrition products that are provided to the patient on a meal tray? For example, Ensure oral supplement, or are you only referring to vitamins, minerals, or a protein powder ordered? So the answer to that is the DRR includes all medications prescribed and over-the-counter, including nutritional supplements, vitamins, and homeopathic and herbal products. And we talked about administered by any route. In this case, it would be oral. So that answer is yes. The next question was, if a physician ordered medication on admission and the pharmacist contacts them prior to them profiling the meds and resolves the question and potential issues, is this still an issue? What is considered real-time problem solving versus issue created and found? So the answer is, if that physician orders a medication and the pharmacist contacts them and resolves it, then yes, identification of a potential as well as an actual clinically significant medication issue counts. This is something that does count as having been identified. You get credit for identifying potential clinically significant medication issue and coding yes, in this case to N2001, communication between the clinicians and the MDs, and actions taken to resolve these issues before midnight of the next calendar day would count for yes when coding N2003. So you would get credit for that as well. The next question is if a physician designee, such as an ARNP, identified the issue and resolved it without an RN or an LPN input, would this still be coded under the item? So this is very similar, and it's yes, if a potential clinically significant medication issue is identified and resolved by the physician designee, in this case, if the ARNP, according to your state, is designated as a physician designee, then the identification and follow-up action does count when coding N2001 and N2003. So the next question asks, for DIR, please clarify physician designee. Can this include RNs or pharmacy techs or NPs and pharmacists only? So I think we answered this during our, this might have been submitted before we talked about this in our presentation, because we did say that each facility determines their policies and procedures for completing the assessment, and CMS does not provide guidance on who can code the DIR items, so you do have to refer to your facility, federal and state policies and procedures to determine which of your staff can complete the DIR. So the next question is what if the order isn't appropriate to be completed until after midnight of the next calendar day? For example, a vancomycin trough with the next dose, isn't the act of ordering it a response? So presently, during the DIR training, we offered the following example where the provider followed the physician's recommended actions that was to address an issue after midnight of the next calendar day. And when we presented that, we said that that would meet the requirement, resulting in coding yes, that the potential clinically significant medication issue was addressed in accordance to the order of per the physician, right? Because the physician had specific orders. So that meant that the example that we provided today was a scenario that was similar, where at admission and any time throughout the patient's stay, the clinician contact the physician designee regarding all the potential or actual clinically significant medication issues, and this was communicated to the clinician. In this case that we gave you, no actions were necessary regarding the reported issue, so all communications took place before midnight of next calendar day. As long as those communications took place before midnight of next calendar day and included in the physician's request and orders was that it did not take place until after, then that counts as a yes. Or again, if part of it was to be completed before midnight of next calendar day and you did that, and part of it was supposed to be completed after, again, that would be a yes. So the next question was, when you say clinicians' professional judgment, what level of clinicians are you referring to? So CMS doesn't provide guidance on who can or cannot code these DIR items, and so again, we refer you to these facility, federal, and state policies provided procedures to determine which of your staff members can do this. And each facility determines their policy and procedures for completing the assessments. So during the admission process, defining current therapy is not always clear. We are using multiple sources of information to best determine this. Would we report a potentially clinically significant medication issue even if we have not confirmed that it's current therapy? Example, poor historian. So if we are interpreting your question correctly as meaning current medication therapy as being not always clear-cut, our response is to use your clinical judgment to determine what resources, as we outlined, all those different resources that you're going to be looking at to determine what, and if the DRR, what would be needed to gather that information. So you use the information you have to reinforce what it is that is considered current therapy. we also have, again, those clinicians in the clinician's manual posted now on the CMS website. You can find more information as well. We had a dash question for N2003 dash. Does this dash count as incomplete? Counts against, meaning counting against the 95% IRF-PAI completion requirement with a 2% penalty for not meeting, or is it similar to the current use of dashes for GD discharge codes? And the answer is yes, the 3 DRR items are needed for the calculation of the measure. If dashed, it would be counted as incomplete and counts against your APU. Another question, does section N need to be completed within the 3-day assessment admission timeframe? So we say complete the drug regimen review admission as close to or at the time of admission as possible to identify these potential clinically significant medication issues. So of course, it would be best practice to identify any issues as soon as the patient as possible. So you will probably have procedures for data collection that you're to follow, and so follow those policies. Facility policies and patient assessments are to be done in compliance with your facility, state, and federal requirements. And of course, you want to take a look at what your patient care is according to their unique characteristics and standards, your patient population. Thus, each facility self-determines these policies for completing your setting assessment. And then one of our last few questions here. All practice examples refer only to acute care discharge documents as the source of information to compare to inpatient orders. Is CMS suggesting that this represents a complete medical med-rec process in the absence of other information sources? And this, of course, is no. We want you to review the medical record, all the medical record documentation that's needed to determine if a DRR was conducted on admission or close to the actual time of admission to identify any of these critically, potential or actual clinically significant medication issues. We listed all the different sources that we recommend that you include, and that was not a complete source, but we did have many on that list. Medical record sources, we did say, include medical records received from facilities or home where the patient received health care, or the most recent history and physical transfer documents, discharge summaries, medication lists, records, clinical progress notes, and other resources that are available. Okay, and we also had a number of similar questions to this. What happens if there were no problems in N2001 code 0? What do you score for N2003? So if N2001 is coded 0 or 9, NA, at admission, then follow the skip pattern according to your PAC setting admission assessment, LCDS or IRF-PAI. In this scenario, you would not need to complete the second DRR admission assessment item, N2003 medication follow-up, due to this skip pattern. We answered that one. And we had one more. Have to get from here. Okay, we had during the presentation, someone had asked about a question about scenario 3. I don't know if she's still here, but for scenario 3 during the presentation, the PAC physician provided orders for lab testing so that the patient's INR level would be monitored over the next 3 days, starting that same day. In this scenario, the nurse did not request the first INR lab test until after midnight of the next calendar day. So the scenario indicated that the MD order was not directly entered into the PAC system and needed to be carried out with further action by the RN, who did not take the action of requesting the first INR lab test until midnight of the next calendar day. I think that concludes our questions, and thank you so much. We look forward to hearing from you on the help desk and submitting your questions there. Thank you.